Closing the Gap project is a sexual and reproductive health and rights service delivery and advocacy project. The overall objective of the project is to increase awareness of, access to and use of quality family planning with focus on the long-acting and reversible contraceptive methods and comprehensive abortion care in high-need communities. In Uganda, the project is implemented in the regions of central and northern Uganda. Planned Parenthood Global partnered with Chetume community-based healthcare program, Flama Uganda, Reproductive Health Uganda and Straight Talk Foundation. This project has been implemented since 2015 with models on youth peer providers, male involvement in family planning, institutional strengthening and clinical mentorship, demand creation and family planning and safe abortion. Let's look at each of the models and how they have helped in achieving the objectives of Closing the Gap project. In an effort to accelerate demand and uptake of family planning and safe abortion services, there is demand creation. This is a model used by Closing the Gap project to create awareness and promote need for family planning and safe abortion services in high-need areas. Peer providers and community health workers are tasked with reaching out to communities and share information about family planning and safe abortion. Joy Natimela, a VHT at Chetume, gives details on how she goes about creating demand.
To go in the community, to sensitize people, to tell them how family planning is good for them. Yes, and to tell them what to do, to come to the facility and help them arrange their families good.
Angwech Grace is a peer provider at Flama Uganda based in Gulu district. These are her sentiments on demand creation for post-abortion care and family planning services.
We normally go to the community, we consult them one-on-one, we talk to them one-on-one, and at times we put them in groups and we communicate to them on a group session.
Youth are trained on how to approach communities. They are also taught basic communication skills.
Community outreaches and community kind of demand creation events. We basically, with CTG, we offer services at a facility level. So at the facility level, what we've done is we have actually attached volunteers on a daily basis. They interchange. When one is in the community, another one will be at the facility. The reason is that still, when they come at the facility, remember the facility, people come to get different kind of services. So these volunteers, their work at the facility is to receive the clients and talk to them. When they realize that the client has come for malaria service, they'll still try to talk to this client and tell them about family planning, so that at the end of the day, a client can be able to be offered the family planning service. We are providing the youth-friendly services. So on the partner facilities that we are working with, we have tried to establish what we call youth corners. And also, these youth corners, the reason is that some youths feel comfortable coming for family planning services or safe abortion services or emergency post-abortion services at a facility where grown-ups, all the people, or they call aunties and parents, are not there. So we decided to to establish youth-friendly services or centers, corners, where they can easily go and get information about family planning. They get services from those corners, from the youth corners, and also have a free interaction with a service provider, because we attach a service provider and a counselor at a youth corner. So they feel it more easier to have access to information when they meet peer-to-peer kind of people at the corners.
Finally, demand creation model has driven the level of uptake of family planning and safe abortion. It would be wise to allocate more resources towards enhancing demand creation. The success of any program is based on the professionals carrying the program. There are various issues that have bearing on quality of family planning and safe abortion services. Health workers have mostly placed blame on inadequate training, mentorship and refresher courses. All the staff in the clinics which implement Closing the Gap project is trained regularly on new development and refresher courses in their areas of their profession to help them in carrying out their duties. Auma Grace of Straight Talk Foundation gives us the details of training she has received.
We received training on family planning, especially long-acting reversible contraceptives. We got training on cancer screening. We got training on how to handle youth-friendly services. We got training on comprehensive abortion care.
The mentorship projects and training have also had impact on the staff at Flama, Uganda, with service providers narrating how the trainings have made their work easier. Oyo Lillian, a service provider at Flama, expounds.
I'm called Ms. Oyo Lillian. I've served in Flama, Uganda for 3 years. I'm a midwife stroke counselor, so I hold the position of a counselor in the project. Well, when I was absorbed here for the project, first it was hard for me because I've been in missionary hospital for quite some time. So joining the Planned Parenthood project, they started giving me workshops. I became closer to family planning. I got to know the benefit much. It was easier for me to communicate with the clients on the benefits of family planning. There, it became a routine thing to me, and it's easy.
Jeffrey Ojok is trainer of trainees at Flama, Uganda. He says there is constant training and value clarification to the youth service providers. They visit partner clinics to train the staff, which has enabled improvement of quality of services in those clinics.
Yeah, my name is Kema Jeffrey Ojok. I work with Flama, Uganda. I'm a service provider. At the same time, the trainer of the trainee under Flama, Uganda. Generally, clinical mentorship has helped a lot. Because like after the training, you know, like some of the service providers, they don't get immediate information. They need a routine revising how they should deliver the service. So as we do have the clinical mentorship, we go into these 12 facilities, which this new service provider will get to know how to deliver the service. We also help them in during clinical mentorship. There is what we call value clarification or attitude transformation. That is VCAT, more especially on family planning and safe abortion. You know, like in the training, you may not get more the details about the service providers. But as we go to the partner facilities, we mentor them. We give them the information how they should deliver the service. They deliver the service to the community. As the client comes, how good they should be. And in that, the number of clients also increases. Because like when you have good service provider who have been mentored, automatically the quality of service will improve.
Clinical mentorship has transformed how clinicians and nurses by enabling them to grow their skills and add their knowledge. In addition, it has helped the service providers gain skills on how to carry out their daily operations and communication skills.
Listen, proper planning in the say, yes, no go do mistake. Them go tell you say, hey yeah, brother, your days will be shining, your future great. Brother, no story, make you no regret. Hey yeah, if not to celebrate.
Nearly 40% of men are doing something to prevent pregnancy. Adoption of modern long-term family planning has not yet reached the required level, with only 10% of men accompanying their spouses to clinics. There is general assumption that family planning, safe abortion and reproductive health are for women. In Gulu District, we find Straight Talk Foundation, which implements Closing the Gap project, with most of its focus on male in the region. Atem Joyce is a service provider at Straight Talk Foundation.
Closing the Gap project came in. We have been able to access the main right up to the ground level, the grassroots level, because We move there ourselves after mobilizing them using our community mobilizers, that is the CHV. And when we mobilize them, we go there, we talk to them, and it is face to face, whereby everyone is able to air out their views. And in that, you find that most of the men didn't know exactly what was being done as pertains this project, and mostly like for family planning, we really need the support of the men, because it is their wives who come to seek for the services, and you find that most women, when they are coming for such services, they have to escape. So with this project, it made it easier for us to reach the men so that they are able to allow their women to come freely and make a choice. And even if possible, they would decide together for the particular method they want.
Auma Grace, a service provider at Bardeng Health Center, narrates her experience creating demand for safe abortion and family planning.
Yes, they are coming together with their women, and even if you ask the women, they are now taking the long-acting, especially the implant on the Jadel, even IUCD. When you interact with them, they say they received the permission, so they have no problem.
The Safe Abortion campaign has been adopted by male youth, especially the school-going youth, who come to the clinic seeking services for safe abortion.
Very many of them, as I told you, others are coming for family planning, but others are coming for those safe abortion, especially the school boys. Yeah, they talk to us, but we encourage them to come with their girlfriends. Yeah, they can.
Gulu youth have embraced male family planning, as Ocheto Jimmy, a youth peer provider at Straight Talk Foundation, expounds.
They come for the family planning services. They come usually with their partners or their girlfriend or boyfriend. They move together. They come and share, talk a lot on this family.
Patrick Pyers, the project coordinator at Straight Talk, gets into details about the number of male who have been influenced to take up family planning and safe abortion, and the methods they have used to achieve their target.
Since the project started, we have reached about 24,000 men with information on family planning, LACAN, and comprehensive abortion care related informations. And these are about 25% of the people that we've reached. We reached in total 97,000 people, and 24 are male. This is about 25%.
Male engagement model involves partners recruiting men. These men are trained to reach out to fellow men being referred to sites for services and doing a follow-up on the progress of male in the project.
2016 at the start, we embarked on the male engagement program. This male engagement program works with the male action groups that have been established at the health centers. And this a team of around 20 men who are in a group. They only don't engage in health-related issues, but they also do some economic activities in terms of income generation. We targeted that group that is formed. It was formed by the ministry and WHO. We worked with them, and as I tell you right now, there's a lot of change in terms of men embracing the family planning services.
Despite the efforts made in the recent past to promote family planning, many women still get hard time in embracing family planning and abortion. There are still many myths and taboos associated with family planning and safe abortion. Rolling out of the CTG project and family planning being one of the focus areas of the project, myths associated with family planning have reduced significantly.
I'm the family planning focal person as well as the in charge of the facility. When we get a client who wants to access family planning services, we go through comprehensive counseling for family planning, and of which here we provide a variety of the methods which we have. We have the IUDs, the implants, the injectables, the pills, and after giving thorough information about these methods, the client makes a choice for themselves, and then after they do consent, and we offer the service.
Sandra Nabatanzi is a youth peer provider at Chetume Clinic.
Information concerning family planning, where we talk about the different family planning methods the microgynon. These are the pills that are taken every day for a month. We have the mini pills for the breastfeeding mothers. We also have the implants. These are between 3 to 5 years, depending on one's choice. And all these methods are aimed to prevent unwanted pregnancies. We also have the IUD, where they insert the copper IUD into the woman's uterus to be able to help them not to have unwanted pregnancies. We also have other methods, which includes, the use of condoms, vasectomy, and sterilization for the women.
We are not protected when offering that services. If the policy, even the policy guideline can be provided, or the country itself, because abortion itself is not permitted in Uganda as a country, and so we are not protected by the law. Secondly, there is need for continuous sensitization of the community on the benefits of family planning, because many parents, they still like the young girls should not start these modern contraceptives. But we really see that there is really need, because many of them are coming for abortion in the health unit. Yeah.
For me, I wanted IUD. I just told them to put IUD.
The name, but it is that one they put in the uterus. That one they put inside the uterus. Yes. Because actually I didn't know, because it was my first time, but I thought of trying it because I heard people talk about these ones, about like some people talk that this one they inject that it has some effects. So for me, I thought of trying this one, because this one they just put it there, and I thought maybe it will not have anything bad. Yeah, at least because it is making my life easier. I'm just sure I will not maybe get pregnant, unwanted pregnant, just anyhow.
In the process of helping those who want to perform abortion, there is a sub-program of safe abortion. Safe abortion has helped in reducing complications and deaths resulting from abortion procedures performed in unsafe environments. Oyo Lillian, a service provider at Flama, Uganda, she talks about the procedure of safe abortion.
This one now depends how the patient reaches me, because sometimes the patient is sent by the YPP down there, or the patient can choose alone to come. Now, if this patient comes, it's also in two ways. It can start spontaneously, of which she may need help, or she may intend that she's not ready for the pregnancy. This one will give me now a clue to cancel this patient in two ways. If this client comes with spontaneous abortion, I'll also welcome her, talk to her and get the history, how the bleeding starts, the pain she's having. I'll also refer this patient for ultrasound, noticing her condition, the level of her bleeding, the level of the pain she's having, giving her also a bit of pain relief. After results is out, I see the results, share with the clinician. There, if now the scan result says it needs to be evacuated, then I will cancel her. Canceling her includes telling her that since it has started spontaneously, you have to rest for at least 21 days, because if within 21 days we helped you cleaning the uterus, you will again conceive. So I'll bring in family planning. So as we are coming to do evacuation or MVA here, she's now aware that after the procedure, she has to get a family planning and walk out with it. Now when we reach procedure room here, we have a smart dress, we give her clean dress, we give her a clean dress as I set my trolley. Setting my trolley, I would have a sterile gloves at the side. I'll have a MVA kit, set them from green, yellow, blue. It is a sterile procedure. Pick a sterile vaginal speculum, position her in a comfortable way. This bed you're seeing here, it is adjustable. Has a pillow, that one for the leg. counsel her on fear. Then there I set my MVA kids that's supporting her. As I also observe, because as I move with the MVA, I will also study the flow of the blood that I'm sucking, and when it is finishing, the froth that it's showing me that she's now done. Clean this mother, let her rest for a while I also observed her, because some other young people can go into shock. I also manage very fast according to her situation. So after I'm done, pad her. If she has the pad, if she doesn't have, I provide. Talk about family planning again, which one she would wish. Along my work, she can decide, sister, give me injectable, sister, give me implano, sister, give me IUD. If she says she needs IUD, I will also talk about IUD, the duration. But if she wants to conceive again, I will use short-term method for her. Then later I will shift her in bed, check on her, start her on antibiotics to cover.
Adong Ping, resident of Gulu Town, decided to have safe abortion after realizing she had conceived 6 months after giving birth.
Then one day I got pregnant, I have a child, but was 6 months older. Then I conceived later on. Then the child was still young. Then I thought of there's something I must do about it. Then I talked to a friend, and a friend told me that there is a project which is in Badege Health Center, which they can help me on that. Then I went there.
I was using injectables. Then, all of a sudden, I got pregnant, whereby I decided, to give birth to that kid who is now 2 years and a half. And again, I went back to my injectables. But I found out I was pregnant. Again, before the kid, you can imagine that the space. Kid is not yet old and you're pregnant again. So it wasn't good. I felt so bad. I was counseled. They told me to keep the pregnancy, but I couldn't, because I was just going to take care of the pregnancy and the young kid. So I was helped and I got rid of that pregnancy.
All in all, family planning and safe abortion services have been beneficial to many women school-going youths. This is attributed to the efforts of PP Global through the Closing the Gap project.
The youth peer providers have been an integral part of the provision and driving the objectives of Closing the Gap project. They are the eyes and ears of the project to the communities benefiting from the Closing the Gap project. Sandra Nabatanzi, a youth peer provider at Chetume community-based project, gives details of her activities at the project.
About the kind of services that I offer, it's where we have the voluntary HIV counseling and testing, where we encourage the youth to test for HIV/AIDS to be able to know where they stand in terms of health. And for those that happen to turn the other side, we refer them to the nearest health centers. Basically, I usually refer to Chetume Health Center, where they are given the full comprehensive package about, HIV. We also give information concerning family planning, where we talk about the different family planning methods. The microgynon, these are the pills that are taken every day for a month. We have the mini pills for the breastfeeding mothers. We also have the implants. These are between 3 to 5 years, depending on one's choice. And all these methods are aimed to prevent unwanted pregnancies. We also have the IUD, where they insert the copper IUD into the woman's uterus to be able to help them not to have unwanted pregnancies. We also have other methods, which includes, the use of condoms, vasectomy, and sterilization for the women.
The exclusive youth centers employed by the peer providers have helped the youth who are shy to engage fully with peer providers. Angwech, a youth provider at Flama, Uganda, narrates how these centers work.
It's when we go to the field to commit the community, especially women and sometimes men, talk to them about family planning, and we are putting much emphasis on the long-term methods of family planning. Those are the implanners. These ones that last for long, the long-term methods. And that has been our major targets. We have a youth corner where always our youth from outside the community that surrounds Flama comes and we share information with them. We also have our pool table where our youth comes and we get time with them as they play around. We interact with them. We ask them some of their health talk. We give them health education, especially the young ones which are not above 18 years. We also have some information that we share with them, and then the adult ones that are above 18 years, we also have times we put them separately and we give them health education, how they should protect themselves.
Henry Kayondo, the project coordinator at Chetume, gives details on the benefits of peer provider model.
Remember, the communities we are working in have different age groups. So we recruited youth peer providers that can help us reach those youth peers, or the peer in their age bracket. Then we also recruited the volunteers that are above the 24 years. And so far, we have 100 volunteers, 60 are youth peer providers, and 40 are they are VHTs. The reason why the YPPs are more than the VHTs, it's because we realized that the YPP model and the people that were so much interested or to reach were the youth. They were the youth. So we thought that when we have a higher number of youth peer providers, we'd get more number of young people coming for the family planning methods and other services that we offer. So these volunteers help us to go to communities where they organize demand creation events like community dialogues, community rallies. They do even door-to-door kind of outreaches, and also one-on-one services like talks with their fellow peers.
In addition, peer providers are equipped with life skills training like sewing, machine operations, and other skills. Certificates are later issued to the youth peer providers. Kayondo says this in the end is a win-win situation for both the project and the youth providers.
When starting the project, we realized that we train the volunteers, and after a period of time, they walk away in search of employment, in search of many, young people have a lot of challenges. So what we decided closely, you can see we have very many youth there. All those are youth peer providers. But the reason why they are there, we try to integrate vocational skills to them. So they feel more comfortable when they know they are doing the service at a voluntary basis, but at the same time benefiting from the organization. So we have air dressing, we have tailoring, we have weaving, we also have electronical skills that we give them. So we have artisan mentors we've employed to give them that skill. So at the end of the day, after 1 year, we actually connect them to one of the institutions around to do the exams, and we provide them with certificates.
The youth peer providers have faced various challenges.
I normally get challenges in the field when I go to give health education in the field, because although people are aware about family planning, but still they have the myths and the misconceptions about family planning, and they normally give us a lot of questions that at times it defeats us, the YPP, and maybe we call for the help from the service provider to come and help us answering those questions. And then there are also some family planning that we advocate for them in the community, but we don't give them, like the permanent methods here, they are not yet here. So at times people will be willing to get it from the field, but when we don't have the access of it from there, because some of the methods we give them from the field.
One of the biggest challenges that we have is the parents themselves allowing, most especially the girl children, to be able to come to the youth center to receive this kind of information. So they are kind of resistant, or for them they think that this information is kind of going like to turn them to the other way around, which is not the case.
I'd advise if they can extend to go and conduct like a health education in the schools or where people can gather, it is okay.
PP Global believes in power of partnership to increase uptake of family planning and other related services. Closing the Gap project was rolled out in 59 health facilities among the 4 partner organizations. There have been acquisition of power, office and work equipment, and as well as monitoring and evaluation. Teddy is the executive director of Flama Uganda.
Global has been the first donor for this organization, Flama Uganda. When PP Global came in, literally Flama Uganda had nothing in place. PP Global supplied to us computers, because initially our work was manual. And they provided training to the staff, and even the human resource force has actually been provided by PP Global. The organization did not have a professional accountant, did not have a project coordinator, personnel that monitoring and evaluation officers were not in place, and of course the rest of the human resource like clinicians and then counselors, data entry and clerk, and nurses and midwives. So Flama had only the technical staff, like the clinicians and the nurses at the beginning.
With the model having driven the objectives of the Closing the Gap project, many lessons were learned in the implementation of project and the challenges that come with it. Daniel Achiri is the Monitoring and Evaluation Officer at Flama Uganda.
When we first assessed our partner facilities, we discovered they were not documenting. They were providing these services, but they were not putting things on paper. So what I learned is we need to encourage documentation and data management aspect so as to see what we are doing. Yeah. If we can do more of community dialogue and we involve the male partners, and that will also help us a lot in bringing for these clients to come for services. Yeah. The project has helped the clients very well, and we have had high uptake of the services, and looking at our client load in terms of the indicators, the performance indicators of the project, we managed to surpass all the targets. Yeah, that was needed for the project.
All in all, the implementation of the project has been of significant help to high-need communities, and many lives have been changed or saved.